Hi, I'm Ken Binmoeller, San Francisco. Pleasure to speak at AWE Week 2024. We're going to unravel underwater EMR. I'd like to start with the definition of EMR. It's important to emphasize that this is a mucosectomy. This is a complete resection of the mucosa, and this is what your specimen should look like. You have to have the submucosa at the base of your resection. This is primarily intended for diagnosis and staging, and that's why what's called strip biopsy or large particle biopsy in the former literature, especially by the Japanese, confronted with a lot of gastric cancer. And it was important to know if the resection was indeed curative. So it has therapeutic curative potentials. Now, there's always this debate, EMR versus ESD, as if they're fighting in a boxer's ring. But the plane of resection is the same. It's the submucosa. We're just using different tools for the resection, a snare versus a knife. EMR can be en bloc, and one should strive to always do an en bloc resection, but obviously the ability to resect en bloc is size dependent. ESD should be always en bloc. So the rationale for submucosal injection before EMR is based on the assumption that you're doing this with gas insufflation, because with gas we distend and we thin out the wall and we flatten our lesion. So to counter the effect of the gas, thinning out the wall, flattening the lesion, we inject into the submucosa. So we're sort of trying to restore the native anatomy of the wall, and it's thought that this will facilitate lesion capture. It will reduce the risk of perforation because the wall is now thicker, and it would reduce the risk of transmural burn, again, because the wall is thicker. But does it really perform with these advantages that it's purported to have? There is no proven benefit of submucosal injection. If we look at the literature, there's never been a randomized controlled trial comparing submucosal injection versus no injection and looking really at the outcomes. We have really just this animal study, 6 swine, and the results were contradictory. If we looked at the heater probe in APC, there was a significant difference in the depth of thermal injury comparing controls and those lesions that were injected submucosally. It's sort of surprising, though, that with APC there would be a difference because APC is supposed to limit the depth of thermal injury. When they use hot biopsy forceps, and we're taught that hot biopsy forceps carry a significant risk of deep thermal injury, there was no significant difference whether you inject it or not. Similarly also for the gold probe. So this is not really convincing data supporting submucosal injection. Submucosal injection may make snare capture more difficult because it distorts and it narrows the lumen. So if you're in a narrow area, you're going to have more difficulty. It may displace the lesion to your disadvantage. Now, of course, it can also displace it to your advantage. For example, if it's behind a fold, then you can inject further away and try to shift the lesion towards you. There can be paradoxical flattening. So this is when the injectate spreads to the submucosal space surrounding the lesion. That lifts more than that space beneath the lesion. So you actually end up getting some excavation of the lesion, and it increases the tissue tension. So the submucosal space, this is spongy tissue. It's connective tissue, very loose. So it's very compliant. And if you inject into it, you decrease the compliance. You make it stiffer. And submucosal injection may increase the risk of EMR if, for example, you inject into this space between the circular and the longitudinal muscle layers. If you inject outside the muscle layer, remember you have an organ that's contracting, it's mobile, then you will get the injectate outside, and that may actually be responsible for pain that we attribute to thermal injury, but it could just be the injection also causing that pain. I noticed, and this is over a decade ago, this was just by accident. I noticed while doing endoscopic ultrasound using a mini probe in the colon to stage a polyp that looked malignant. I wanted to know if it was invading more deeply. And I noticed that the mucosa and the submucosa, they involute into the lumen, but the muscularis propria stays round on the outside, even when there's vigorous contractions. So here you can see the contractions, the peristalsis, and the mucosa and the submucosa, it involutes, it folds in, but the MP stays round on the outside. So you see this. So seeing is believing. And that led me then to postulate that we can safely resect these lesions without submucosal injection, but we have to submerge the lesion in water or saline. So we get this floating effect. Here's the appearance with gas, very, very flat here, kind of like a 1S, right? Now after water submersion, this lesion floats and it really looks as if we had injected into the submucosa. Of course, we didn't, but that's the appearance that you get. I call this a souffle effect. It literally just floats right up. And why does it float? It's because the submucosa contains fat. So as mentioned before, that's also why it's very loose and spongy. And you see this fat then when you do a resection. On CT, this looks like, this is called the black halo sign. So the fat appears black, but on EUS, the fat is echogenic, it's bright. And that's why that third layer, the submucosa, is echogenic, the white layer between the deep mucosa that contains the muscularis mucosa and the muscularis propria. So muscle is dark. So underwater EMR is performed without submucosal injection. So we have the flat lesion, floats up very nicely, souffle effect, and the lumen contracts. Allows us to ensnare the entire lesion for the most part, unless they're extremely large, and this is the appearance after the resection. So the conceptual advantages of UEMR are it eliminates the drawbacks of submucosal injection because it retains the native tissue consistency, doesn't become stiffer, stays spongy and loose, so it just makes it easier to capture with your snare, and it retains the natural wall layer separation. Very important because when you're injecting, you're not selectively injecting the submucosa. I mean, you may see it sort of raised, but there's peristalsis, and that needle is moving between different layers. So you may also be getting injection into the muscularis propria, between the two layers, as mentioned before, and maybe outside. And we have a contracted lumen. This is very important because when the lumen's contracted, we can capture a larger surface area, get more real estate, and this enables a higher en bloc resection rate. And we can reduce the collateral thermal injury because of the heat sink effect that water has. So the thermal energy is diverted to the water rather than to the deeper wall layers. So here's how I do it. High def adult colonoscope. I think most units have these now, but you need near focus. That means you need an adult colonoscope. That's currently the only one that has that. But I also like the larger working channel so that I have good aspiration alongside my snare catheter, for example, or biopsy forceps, whatever it is that you have in the scope channel. A transparent cap mounted on the tip, pretty standard. That cap is very helpful to flatten out folds and just keep a certain ideal focal distance away from the mucosa. And then the irrigation pump. It's hooked up to the auxiliary water channel, and so you can see that here with the arrow hooked up here. And this is what I call the water jet channel. And so you can infuse continuously sterile saline. So we call it underwater, but it's really under saline because we want the conductivity when we apply diathermy. You can add a dye or so to it, but I usually don't. And this is foot pedal controlled. Now the snare just has to be sniff, and these snares come in all configurations. This duckbill is very nice if you have something along a fold because it opens up a little bit more horizontal. Otherwise, just your standard oval snares here, and they come in different sizes. I tend to use the largest one because the polyps sent to me tend to be pretty big, so I'm pretty much using a 33 millimeter snare for most of my resections. These are the cautery settings I use. We had the Vial 300, formerly using this, now we've switched to the Vial 3. So the settings are slightly different, but in both cases I'm using pure cutting current, so auto cut. And if the patient has higher bleeding risk, then I will use dry cut. In fact, 580 watts. On the Vial 3, that would be 4. I do like to make little dots, diathermic dots around the perimeter, and I will use the snare to do that, but the snare is recessed in the catheter. So I never have the snare sticking out from the tip, because then you can poke holes into the wall. And of course, there's no submucosal injection as a buffer, so you need to be careful. Of course, you use soft coag for that. If you do need to perform hemostasis, let's say with a hot biopsy forceps or a coag grasper, I use forced coag. And I cauterize the margins, again, with that snare tip, but recessed using soft coag. I always attempt en bloc resection, pressing the snare firmly against the wall. Ideally, I have this at the 6 o'clock position. And I will manipulate the snare to displace the lesion into the open snare. And there are various manipulations. Nice names: to fro, side to side, torque and crimp, rock and roll. Gentle suction, that's the water pull. So, you don't get a red out when you're underwater. If you have gas and you suck, you'll just collapse the lumen completely and very quickly, but with water you have that more graduated contraction. And I wait for peristalsis, actually. When it contracts, you saw that in the video, the muscularis propria still stays round on the outside. And then the margins. I interrogate the margins after the resection very carefully and with near focus and even underwater. Or if you don't have near focus, then definitely use zoom. It should be optical zoom, though. And if there is any macroscopic residual, then you can trim, whatever is left there with a small snare. Typically, I'll use a 10. And this is optional, but we have a protocol, so I will biopsy the margin. Certainly, if anything looks like it could be residual, I'll biopsy and maybe even ablate the margins, using either the biopsy forceps, closed of course, or you can use the snare tip, as I told you, the snare recessed in the catheter. So now some videos to end. So this is a 2A non-granular LST in the cecum with a mucus cap, right? So we're thinking SSA, of course. So now you can see I'm fusing water. We get a nice distension of the lumen with water. NBI is wonderful for these SSAs because you can see the margins very, very clearly. So for these SSAs, because the margins can be very subtle, very indistinct, I want to be close up with near focus, and then I'll place dots around the perimeter. And it's really about placing these dots where the mucosa is normal. It's round, it looks normal. The trained eye can very quickly see what's normal and what's abnormal. And so I'm just going around the perimeter here. Now, I'm not doing ESD afterwards, so you don't have to have these dots so close together. The dots can be a little further away. It's just so that you have some orientation where to place your snare. You just want to make sure that your snare is fully encircling the lesion, and ideally you have some margin around the lesion so that you can get a true en bloc R0 resection. So here's the to and fro, slow water pull. It's gentle sucking, and the lumen's not going to collapse on you. It's going to very slowly contract as you're sucking out the water, and then you close the snare. And you can see the dots there, by the way. You see them here. Here are the dots. So we're definitely outside of the dots. and therefore more likely to have an en bloc resection. So the margins appear clear here. Our protocol is to get some biopsies along the perimeter. So this video is not playing too smoothly right now, but get some biopsies from the perimeter, and you can ablate the perimeter if you like. All right, we'll go to next video. This is a non-granular type LST along the fold. Now this is not an SSA. You can see it doesn't have a mucus cap, and it has a different pit pattern, different from that lacy appearance of SSA. So let's watch this video. So it's along a fold, so more longitudinal, and underwater, you can see it actually appears to have some slightly depressed areas. So I would go as far as saying 2C. And notice the difference in the pit pattern here. So it's a little jerky, the video here. I apologize, but I'm making just dots around the perimeter as you saw earlier. Here then some more dots. So we've got dots around the perimeter along this fold. You see the fold above and below. So here's our snare. Probably a little on the large size. You could probably get away with a smaller snare in this case, but there's no harm in capturing a little bit more tissue around the perimeter. I mean, it's really about getting that en bloc resection if possible. So this is all a little sort of jerky and slow, but it's maybe good in terms of the teaching here. Now, this looks like a readout, but it wasn't. I mean, it's really very graduated. So now the snare is closed. The nurse is just holding it closed, by the way, and then I wait for some bubbles and for some blanching. And now it's off, and you inspect the perimeter. Those dots are helpful because it allows us to confirm that we really have the entire lesion. So if you see some residual dots, if you place them close to the lesion, then that is something you should trim off. So here you see the resection base. Now the level of resection is SM2, deep SM2, maybe superficial SM3, but you're still above the muscle. And that's why you're not seeing the muscle fibers like you do when you do ESD. You see that connective tissue, with that crisscrossing. So that's, I think, the reason why we don't see much bleeding when we do EMR using the underwater technique versus conventional, where you often are really right there on the muscle, if not sometimes in the muscle, as I mentioned. All right, so some clips afterwards. I always close my lesions with clips now because we have such a beautiful array of clips. All right, let's go. This is the last video. Hopefully this one will play a little faster. So again, my apologies. This is on the IC valve. Well, it's not on the valve itself per se, but along that fold that's at the extension of the IC valve. So it's along that fold on both sides. Now this is a very difficult location because it takes a dip down towards the cecum. It's like a valley. You're going downhill. So great for skiing, but not so great for resection. So now I'm making dots around the perimeter just as you saw before. So this is just my protocol. You don't have to do this. I mean, you can see very nicely where the perimeter is. But the problem is that after you give cautery, everything kind of looks like adenoma suddenly. So it's nice just to have those dots. Now in this case, because it makes that dive down into the deep valley of the cecum, I'm injecting. So it's not like I never inject. It's just I'm not injecting through the lesion. I'm injecting behind the lesion. And I want to raise that recessed part of the cecum up a little bit so that even with the floating effect, I'm really going to get the entire lesion in one piece. So it's about the en bloc resection. I think you could do it piecemeal, get the front part and then go for the back part afterwards. So what I'm doing now is I don't want that snare tip to flip up. I want it to stay flat. So to encourage that, to promote that, I'm actually digging the snare tip with some cautery into the submucosa. I think it's actually really good that it's so jerky because it's really allowing you to see this nicely step by step. So now we're opening up the snare. This is the largest one, the 33 millimeter. But here you can see that that snare tip could easily, if it weren't anchored, it could easily flip up, and then you're not going to get that backside. I use the jiggle maneuver, and if this video were to play normally, you'd see the jiggling occurring. Now it just is kind of frozen. But I'm jiggling back and forth with the shaft, and that helps encourage the lesion to float up more into the snare. So the nurse is closing, initially just holding, I'm not pressing on, I'm not cutting through yet. I'm trying to get that optimal position, and then I apply the current. And as I'm applying the current, the nurse is still not cutting through, just holding until we see bubbles and we see some blanching. So this is where the coordination and training of your assistant is so important. And my foot stays on the pedal. That's the yellow pedal, pure cut. The whole time, if you tap, then you're going to get you're going to get a different effect. That may actually be more like pure cut. By keeping your foot on the pedal, you're actually getting just the right amount of coagulation. And that's why we have the effect 5, that adds coagulation. All right, so now you see the closure, and I love this clip. It's the dual action tissue clip, and you can capture the distal margin first, in this case, so the oral away from you first, and then you just, like a sheet, just pull it over to the margin closest to you, and so the proximal margin, and then close. And that brings the widest diameter together at the midpoint, and then you can just close the remainder of the defect with standard clips. So you go to the right side first, and then to the left side. I will post this video, and then you can watch the procedure in true real time without the jerkiness. All right, so the main drawback of UEMR really is this cloudy view that you get either when you have some residue, some food residue. You just have to keep irrigating. You got to do what's called water exchange. So, dirty water out, clean water in, and keep going. Keep cycling. And if you get bleeding, it's vigorous bleeding, that is. Because if it's a little bit of bleeding, it's actually really nice. You can see exactly where the bleeding is coming from. I'm sure you've seen some videos of that. But the solution, if you get that cloudy view, is just work really close to the mucosa. And then as you're infusing water, it clears the view. So what can UEMR add to your practice? Well, firstly, if you perform underwater colonoscopy, it really is a seamless transition to UEMR. In fact, you can do underwater polypectomy, polypectomy first, just with small polyps. You can use a cold snare for that, which is what I do. So if anything's less than a centimeter, I just cold snare it, but I do that also underwater. Not because I think for polyps it's better to do it underwater. You can use gas, but I just don't want to have to deal with having to suck out the water and replace it with gas, and then the reverse. If you have a high post-EMR recurrence rate, like more than 10%, I would say try UEMR, because the recurrence rates have been shown in numerous studies now, many also randomized controlled, to be lower. It may facilitate the removal of difficult and scarred polyps, and it may decrease the EMR resection time. Now I say EMR resection because you're eliminating saline, but I think you make it a lot easier too. So you're not just saving some steps, but I think it really does become easier, although your total procedure time, if you're not versed at using water and having to put the water in, take the gas out, that can take a little bit of time. So I think you're ready now to make that plunge into underwater EMR. Thank you.